Now I'd like to welcome Dr. Celisa Flores, and in this talk, she's going to explore the potentials of psychedelic treatments within the context of substance use disorders. Early reports from the CDC indicate as much as a 13% change in those reporting starting or incoming substance use during the COVID-19 pandemic. As alcohol, tobacco, and other addictive substances can decrease the immune response, it becomes even more essential to consider the risk of substance use disorders during a pandemic. So this discussion will help you understand the uses of psychedelics for substance abuse disorders and directions for the future. So Dr. Celisa Flores has worked as a therapist, program director, and clinical outreach professional in a wide variety of mental health and substance use disorder treatment settings since obtaining her master's degree in 2007 and a doctorate in 2013 in clinical psychology. Additional training as a yoga and meditation facilitator, as well as a doula, she's been able to draw from a variety of modalities to support self-empowerment and recovery. Her roles included national and international training and speaking engagements on eating disorders, mindfulness, yoga, body acceptance, and professional wellness, as well as facilitating psychedelic integration groups with Psychedelia in Orange County and online. So welcome to you, Dr. Celisa Flores, and take it away.
Thank you so much, Paul. Thank you. Thank you, everyone. So I'm going to leave some time at the end for question and answers. If you have a question that is burning, Paul has so graciously offered to watch the chat for me and the Q&A section. So feel free to add any questions in there if you'd like. Otherwise, you can feel free to just relax and enjoy the presentation, and we'll get to the questions at the end. So let me... So a couple of things. I want to start with just talking about addiction and how we define that. Addiction is a primary chronic disease, and specifically related to brain circuitry of motivation, reward, and memory. And a lot of what happens during an addiction, be it to a substance, to a behavior, to an activity, we often see repeated use in spite of serious consequence, which includes difficulty recognizing those consequences. So somebody might not have even noticed that it's impacting those around them. A lot of times people with addiction often become focused on whatever their addiction is, that they don't notice that other people have noticed even, or that other people have been affected or impacted by it. One of my favorite descriptions of addiction or problem use is that if problems happen when you're using, it's a problem. The use is the problem. So an addiction cycle, I'm going to move my... I don't know if you guys can see the pop-up, but I can. So I'm going to move it out of the way. Addiction cycle here, and that is, we can see there's an emotional trigger, craving, ritual, using, followed by guilt, which is another emotional trigger, which continues the cycle. So addictions are formed around what's available at the time. And that could be a substance, but it could also be shopping, sex, over-exercise, gambling, self-harm. There's all workaholism. So there's all sorts of ways that this can show up. But usually the way that it manifests, at least initially, is what's available at the time that the first emotional trigger was so overwhelming. All of those things that I had identified, the substance, eating disorders, self-harm, those are all the same brain pathways. So it's important to recognize there's no real hierarchy of, you know, at least I don't, right? That's a common experience in the addiction world of, well, at least I don't, whatever it is. But the reality is it's all the same brain pathway. And if something else had been available at the time that the trigger initiated, then it's very possible that the person's at least I don't could have been very easily their experience. So just some things to consider when it comes to addiction. One of my favorite speakers about addiction is Dr. Mate, and I love this quote. The question is not why the addiction, but why the pain. So this is an effort to find self-soothing because at the formative years, people didn't have that soothing available to them. And so I'm a nerdy brain person, so I want to talk a little bit about the neurobiology, and I will share some of that with you guys. And here's another addiction definition from NIDA, the National Institute of Drug Abuse. And there's imaging studies that show that brains change as a result of addiction. But the big question to me always is it cause or consequence, right? Is the addiction because your brain was different to begin with, or is the brain different because of the addiction? And it's probably both. So here's some brains to look at. The one on the left is it's actually the dopamine receptors and how metabolization of dopamine decreases with use. We can see that the red there in this is more active. There's more receptors available, and use decreases the activity of these receptors. So there's less dopamine receptors available. And the role of dopamine is that it helps us to feel good. It lets us know that we are satiated, that we have received pleasure, and that, as we see over time here in these brains, decreases. Another person that does a lot of brain imaging, SPECT, fMRI, and PET images is Dr. Daniel Amen. He has a collection of brain images, and his website is really cool. You can look up any topic or mental health condition and see what brains look like. The benefit of that is that you don't have to pay the thousands of dollars to get your own brain scanned. There are generalities that they can apply and traits that they have applied based on some of the brains that they've seen, and he's seen thousands and thousands of brains. So this is a 3D image of brains, and it is based on it. You can see the variations based on use of drugs, different substances, and different time frames that they have been using them. The places that look like they are holes, they're not actually holes in the brain. They're just areas where there's very little or no activity. When I was a kid, there was the DARE program. And the DARE program taught us that once you've ruined your brain, you can never repair it, which I understand was an effort to kind of use scare tactics to keep people away from ever using substances. But the reality is that's kind of a disempowering space to operate from. So we didn't even know until 1998 that the brain actually regenerates and neurogenesis can even happen. We didn't know that until 1998, which is much later than the DARE program started. So there's all this progress that's been made in the time since then, and I'm happy to say that brains can improve over time. It just takes some conscious effort. So there's a couple of things that I like about this this image, and this is the brain of somebody who has been using cocaine. So the one all the way on the left, we can see this is the frontal cortex. This is the part of the brain. So this is where your eyes would be at the top here. So this is the part of your brain that's in charge of decision making, planning, impulse control, all of those things that happen in the brain. The back of the brain is the occipital lobe. That's the part that's in charge of the vision and perception and memories. So in a comparison standard brain, we can see that there's a lot of activity around the ring. Again, the red is more active, yellow, and then as it goes to blue, it's less active, right? And this also, here in the center, there's an X that is in the comparison subject of yellow activity that's pretty active here. 1 week, and that's an emotional center of the brain. So that's just what it looks like normally. As we move over 1 week into use, it's almost like that middle emotional center has completely gone offline. It's very faint. And then a lot of the area of the frontal cortex with the brain making choices is kind of offline as well. And then as we see over time, there is some increases in that emotional center once again. Usually it's motivation. People are very focused and motivated on finding their substance of abuse. So this is the part that I really liked. And so this one is from Dr. Amen. And he has done all these SPECT scans. And one of the other things that he compared was a healthy brain here on the left, just a standard operating system. And again, the red is more active and the white is more active. And then this is the brain of someone with PTSD, post-traumatic stress disorder. There's a lot of activity in that emotional center. So if we look at this brain, healthy person, and then their brain suddenly shuts off the emotional centers of the brain. If you have been running with PTSD and your brain has been overactive in that center of the brain, it sounds really inviting to get that to be quiet for a little while. This is not only in relation to cocaine, it's in relation to lots of substances of addiction, including sex, gambling, shopping, any of those things that are behavioral addictions, even internet, gaming, all those sorts of things. The brain kind of goes offline in those emotional centers. So I think that's a really important piece. I always like to highlight that people's brains were probably functioning different to begin with in this little section here that we can see. And it sounded really enticing to that brain to get some time to have some peace. So trauma is, now we kind of are in a space where we're able to understand that trauma is not, we don't call things necessarily genetic anymore. They're biological, because we have a genetic predisposition, but that doesn't necessarily mean that that's how it's going to play out. That doesn't mean that that's exactly what's going to happen. So we are not victims of our genetics. We can change the way that our genes express themselves, which is amazing, and we didn't know that 20 years ago. But it is impacted by lots of things in our environment, like stress, like nutrition, like nurturing and support. So because of all these variations, people have different levels that, you know, when we go back to the other brain and saw how dopamine was metabolized, it decreases as a result of certain substances, but it also can decrease there's less receptors available as a result of things like trauma or stress. So those are all things to take into consideration and just be aware of. And I know that was a whole lot of neurobiology. I don't know, Paul, are there any questions or anything that we should attend to? Paul's muted. Okay.
No. Can you hear me?
Yes, I can hear you now.
Yeah, no, everything's clear as far as the questions right now.
Okay, great. I just want to make sure. That was a lot of neurobiology and science. So I just want to, if there's any questions, if any of that seems confusing or overwhelming, please feel free to let me know. I love talking about that stuff, so I'm happy to break it down further. So there actually, when I first wrote up this presentation, it was 13%, and that was actually in the month of April. There was a 13% increase of relapses and substance use in the month of March and April. Since then, in August, it was reported that it's now 18%. So drug overdoses have increased by 18% since the coronavirus started, which is just a shocking number. I have worked in treatment for 16 years now. So I'm very aware of the trends and things that typically when people find treatment, there's definitely times where there's an increase for adolescents and teenagers. We see over the summer, kids don't go to treatment. Families are home, teachers aren't reporting that there's problems, so kids don't tend to go to treatment, and families go on vacations and they have plans and things like that, so kids don't usually go to treatment. But as soon as school starts, by September, October, we tend to see a pretty sharp increase in kids going to treatment, because now school is overwhelming, it's exacerbating any symptoms they might have had, and not just the family is observing it, but there's sort of this third party of a teacher or a school counselor who's saying these are issues or concerns that need to get addressed, so kids end up in treatment. The same is true with adults in treatment. There are seasonal time frames that people go, so just something to consider, but 18% is really pretty significant, especially in relation to overdoses. Another thing, alcohol, tobacco, and lots of other addictive substances tend to decrease the immune function. Again, going back to that, it's not just genetic. There is a biological variant, and stressors tend to exacerbate that. So just another thing to take into consideration, and another reason why it's important to address substance use disorders. Another quote from Dr. Gabor Mate: "Not all traumatized people become addicted, but all addicted people were traumatized." And also part of his definition of what trauma is trauma is not just the bad things that happen. In the treatment world, in the therapy world, it's often referred to as big T trauma, is an event, a thing that happened. But according to Dr. Mate, also, it's the good things that should have happened that didn't. So not having somebody there to nurture you, not being able to have access to, daily care, concern, a loving voice, a touch. There's all sorts of things that people are deprived of that don't seem, or they could dismiss as they weren't traumatic events, but it's wired our brains differently to be receptive in different ways, right? We have different amounts of receptors, and we have different amounts of neurochemicals that are even available. So all of that is to say that trauma does have a big impact. And unfortunately, because there has been a worldwide pandemic, lots of people have experienced trauma in different ways that they were not anticipating or prepared for. And we've all been in a bit of watching and waiting to see how things will unfold next. And that uncertainty definitely increases the experience of trauma. The greatest risk of trauma is not the event itself, but the distortions that we create as a result of the trauma. So, because one of the things that from the quote previously was, it's not everybody that has a traumatic experience or a traumatic upbringing is necessarily going to become addicted. But for a lot of those people, maybe they were able to address the trauma in childhood. Maybe they had somebody that was caring and compassionate that helped them to work through that trauma, or they had some kind of inner resources that were available that helped them to get through that experience. And sometimes the other people that do become traumatized and also have an addiction as a result, or relationship issues as a result, or whatever the case may be, it's often the messages that they learned about the trauma. So if someone didn't receive nurturing, or their parents were depressed and so they were emotionally unavailable, the person internalizes, the child's narrative is very self-focused. So the child always interprets anything happening around them as resulting from them, that's developmental, that's what they should experience. But because of that, if the parent is unavailable, their interpretation could be that I was unlovable, that love is conditional, that that the needs that my body has are not valid, right? There's all sorts of things that we can interpret small traumas as, and I don't mean to say small traumas, they are traumatic, but things that are not a single event get misinterpreted and distorted and shape our worldview in a way that can be detrimental for the rest of our lives. So again, I have worked in treatment for quite some time, and with any chronic medical condition, cure is not the expected outcome. But somehow we've come to a place where we equate relapse with treatment failures. So things like diabetes, asthma, hypertension, the goals for long-term treatment are things more like reducing pain, prolonging life, improving quality of life, and then reducing the harm of symptoms. But it's somehow still equated to be very controversial to have any harm reduction services provided in substance use treatment. There's a lot of pushback on needle exchanges, on safe sites to injection sites, things like that, because we've assigned a moral value to this, right? We've assigned a moral value to addiction when the reality is this is a brain injury. There's a brain issue, there's circuitry issue, there's something wrong that has led this person to continue to make these choices in spite of the consequences, right? If it were so easy to just stop, then it wouldn't be an issue at all. So relapse rates associated with drug addiction are similar to the rates associated with other chronic medical conditions. And this is also from the National Institute of Drug Abuse. And you can see here, I know lots of people that have been diagnosed with type 1 diabetes, and it usually takes them a year to accept that diagnosis and start to make changes. And they can make really significant changes, but they do sometimes need that time to adjust and adapt their life accordingly. So again, all of these things in terms of treating chronic illness, we accept, and we also recognize as progress. So if somebody brings their blood sugar numbers down to a substantial amount for them, but that's not back to baseline of what is considered healthy, we would still be glad that they were able to reduce their blood sugar numbers. However, when it comes to addiction, if someone is no longer using daily and they're able to integrate back into their lives, we have somehow equated that with a failure, that harm reduction is not good enough. So I really do want to challenge that idea that this is a lifelong condition, that people's brains have been impacted, and it's going to take some significant amount of time to have some rehabilitation. Not to say that it's impossible, but it's going to take some time. And our expectation is, well, you went to treatment for 2 weeks. I don't understand why you're not better, right? So the National Institute of Drug Abuse, they recommend residential treatment for at least 90 days. And part of that reason is it just takes at least that long for the person's brain to start to recover and restore back to a healthy state. So their sense of addiction treatment has two components: the treatment and then the continuing care. And there's no single treatment that's going to work for everyone. The things that they have identified as ineffective are boot camp. I'm from a community where that's the standard. That was the standard approach to kids. If they were using substances, they would go to boot camp. Intense supervision doesn't actually work. People just figure out how to engage in their addiction secretly. And then generic case management. Things that are more effective is residential treatment, again, helping the person to get out of their environment in a supported environment with a community where they're learning treatment, they're learning new skills and new coping. Cognitive behavioral therapy is the standard for most types of therapy. Most types of diagnoses are treated with cognitive behavioral therapy. Contingency management, that is to say, if you are sober for X amount of days, you are able to do whatever it is you may. So things like using cell phones in residential treatment are often used as, you know, if we can trust you and you will not make calls to obtain substances, then you can use your phone. But we need evidence that that's going to happen. And then medications are considered more effective, which includes for opiates, there are a number of medications that help with that, and alcohol as well. So how do psychedelics help address addiction? If you are in any way, shape, or form familiar with addiction, you might be familiar with Alcoholics Anonymous, which was founded by Bill Wilson. Bill Wilson was, and part of the foundation is this spiritual experience, right? It is a spiritual treatment to addiction. Bill Wilson, which is not as a lesser known fact, and maybe it's known in this community, but Bill Wilson did take LSD as part of the experiments with LSD in the early 50s. That was at the Los Angeles Veterans Hospital. And in reference, Aldous Huxley, his quote here was in reference to Bill Wilson, who founded AA. So he affirms that his experience under the drug is identical with the spontaneous experience, which changed his life. The only difference being that the spontaneous experience did not last as long. So there's a lot of Bill's references to what Bill's experience was, that he had a very ineffable experience and mystical experience, that he felt that LSD could be a way for people to really start to connect with that God that they may have had an aversion from. And I do see somebody pointed out, yeah, that he also experimented with belladonna in 1934. So belladonna is another hallucinogenic substance. So Bill Wilson had these mystical experiences that were induced by psychedelics, and he did find that was identical to his experience of God. He was raised in a very religious family. He had a very religious upbringing. So to him, that was an essential component to recovery and finding something that was greater than ourselves to use as our foundation for coming into recovery. So the rates for recovery with Alcoholics Anonymous, about 27% of people stay sober for 1 year or less. It's about, let me see. So 14% of people that attend AA are sober between 10 to 20 years. It's a fair rate, right? But also we have to take into consideration is, what is our expectation of sobriety? Is it complete abstinence? Is it harm reduction? One of the struggles is that Alcoholics Anonymous does oftentimes have a hard expectation of complete abstinence, and that doesn't always work for everyone. That's not always a reasonable expectation for every single person that goes in there. I have definitely heard AA members who felt that even taking an antidepressant would diminish their sobriety, which I don't think is true at all. I think it's treating a separate issue, or maybe an underlying issue to the addiction. So there's a lot of uncertainty in the world of AA and 12 steps. And I think it can be a really helpful and wonderful way for a lot of people to build community and have support, but it's not for everyone, and not every treatment is going to be for everyone. So with Bill Wilson and his mystical experiences, let me see. There's something that happens. So psychedelics can create or enhance mystical experiences that have long-lasting impacts on moods, attitudes, behaviors, and this is validated with there's the mystical experiences research, and that's all really fantastic, and there's tons of evidence. And it's not just self-reported, it's reported by people in the community, so that the study is there, and that's people that not only did they identify that they had long-lasting impacts on their moods, attitudes, and behaviors, but also the people around them thought that. And I really love this graphic. This was created on a blog called Sapien Soup. It was based on a meta-analysis of altered states of consciousness, but there are, and you can see at the bottom here, there are different substances and what the experience is most reported by the user. So there's changes in perception, changes in self-regulation, and that oceanic boundlessness, which is really just, you know, that's it, right? Like that's where we all want to get to, is that boundlessness. And so the 4 areas of the altered states of consciousness are mystical, which includes unity and sacredness and knowing. Also, it is positive mood. It is ineffable, that is, there are no words that could explain it. And the transcendence of time and space. So I love this term, psychoplastogen. It is a word that was created recently by Dr. Lee and a couple of his colleagues at, I'll show you on the next slide, but this mind molded producing. So psychoplastogen, there are very few substances that can induce reliably new growth in the brain, but psychedelics is one of them. So we see here, this is their diagram of what happens, what psychoplastogen looks like. And they tested a number of substances. You can see at the top there, that's what the brain looked like before a synapsis. And they applied these different substances. And again, this is just the standard, what it looked like before. And we can see the dendritic growth here that happened, and that there was an increase in the number of new growth and also the thickness of the spine. So they found that this resulted from DMT, LSD, MDMA, and noribogaine, which is the metabolite of ibogaine, but not from ibogaine itself. At first, I think they initially tested ibogaine. Ibogaine breaks down in the human liver. It breaks down to noribogaine, and that did show neuroplastogenic effects, but ibogaine itself did not. So there's some interesting understandings of research that we have that are just that we don't necessarily, it doesn't always work in a lab, right? Like the things that are, we can't just extract one piece of it and expect that that's going to have the same impact as the whole plant or the whole ritual or the whole ceremony or whatever the case may be. So just a thing to keep into consideration. Yes, psilocybin is also a psychoplastogen. That was not one of the things that they initially researched, but there was a second study after that they had been able to apply that to. So yes, it is. So psychedelics, there was some of the early research was with psilocybin and smoking. And there was really fascinating. They did a study in 2015 and they had 15 participants. These participants were people who had been smoking for an average of 20 years and had tried to quit with different methods at least 3.5 times, right? Almost 4 times on average. They had kept trying to quit. Nothing that they really found worked. On the market, the thing that we have that works best is about 10% effective. It works for about 10% of people. So then these people were in a 15-week program. They were given 2 doses for sure of psilocybin, and the third was optional. And then 12 of them at 6 months had still quit. They completely quit, I think, at 5 weeks when the first psilocybin dose was offered. After that was when they quit completely. 10 of them at 1 year remained abstinent, 9 in 2018 when the follow-up study was conducted. And one of the really interesting things during the follow-up study, a lot of the people that had reported that they forgot that this was about smoking, because smoking was the least significant of the things that changed during the time that they had their mystical psychedelic experience and the follow-up study. This research was based on out of the 50s. It was based on the research from the 50s where it was really focused on the mystical experience. So they correlated how many people had mystical experiences. Of the 3 people that did not quit smoking, one of them did not have a mystical experience at all. One of them had a very negative or challenging experience. And that was just kind of that was the result of what had happened from the people that quit versus the people that didn't. A lot of the things that people did report years later in the 2018 follow-up that was that their quality of life had improved and that they felt they were living more in line with their values. So some of the things that people said was they had been artists or poets and they got back into that. They felt that they were better able to be parents, that they were better members of society, that they practiced general courtesies that they hadn't before, that they noticed a reduction in their anger outbursts. So there was a lot of things that really changed and shifted for people that were not what was being researched, and it was not what they necessarily expected, but that was the result of the study. And so, like I said, so many of them forgot that they had initially signed up for the study to quit smoking because that was, as they said, the least of the things that they were concerned about. Psychedelics. So also LSD was used for treatment of alcohol in the 1950s to the 1970s. That was when research was still allowed to some degree. So it was often used with people that were in hospital settings, which were something that was available in the 50s and the 70s, that there was a hospital for people to go to get treatment. This was happening in Canada, in the US. We don't have the best data because they were not, the studies weren't consistent. We don't have a lot of information about dropout rates, and they weren't large studies. So people we are able to do now in review, they were doing a meta-analysis, which means they take all the information from before and compile it and use that data. So one of the things that they showed was that it was almost 2 times improvement over the control. So people that did not take the single dose of LSD at follow-up had a significantly decreased rate of addiction or continued use of alcohol. 1.8 over 2 to 3 months, and then 1.6 at 6 months. No significant findings beyond 6 months. But again, I kind of go back to that idea of this is a chronic medical condition that has impacted people's brains, and to have this was a single dose of LSD that did not include therapy, that did not include integration, that did not include therapy on any ongoing level. The people were just kind of let back into the regular lives, which is the challenge, right? So I think it's pretty significant that at 6 months, even a single dose of LSD had that big of an impact for people. And then opiates and ibogaine. So this is the ibogaine bush. So ibogaine trials have shown rapid detox from opiates that are statistically significant and decreases for cravings, as well as improved mood scores. This is not only self-report. Again, this is reports from physicians and providers that are available. But because fatalities have occurred with the use of ibogaine for substance detox, it's usually at higher doses, but there's a lot of uncertainty about it. It's not something that's researched heavily. And like with some of the other substances that I'll talk about next, There's just not any, there are no double-blind studies, right? There's no study that we would consider in the West as the gold standard, which is that the participant and the medical provider do not know who is receiving which substance. Um, Part of the reason, and I'll talk a little bit about, this is ayahuasca. This is the flower from ayahuasca. Ayahuasca, peyote, and wachuma. So there are no double-blind, peer-reviewed studies in the literature. And part of the reason, so any evidence that we have is anecdotal. And part of the reason is these are longer lasting substances. So ayahuasca, peyote, wachuma, and ibogaine can last up to 8 to 12 hours, which is financially challenging. It's difficult to have two, if it's done in the MAPS model where there are two providers for each participant for 12 hours. That's very taxing financially and physically for the providers and for the participant also. But also, peyote is one thing that is not, it's not harvested in a sustainable way. It's very difficult. So right now, it's not necessarily something that I would advocate for people to take as an experiment, just because it's not sustainable, it's difficult, and that makes it limited to the people whose culture have used it culturally. Wachuma is a cactus with similar properties that grows very freely. So if people were in the experimenting world, I would recommend researching wachuma over peyote, again, for the same reasons, just because of the environmental impacts of it. So with that, there's lots of reasons that we just haven't seen research yet. There have been brain scans that were done in Brazil, and part of that was the immediate impact. The other side of wachuma, peyote, ayahuasca is it's typically, and ibogaine are typically done in ritual settings. That gets lost, right? That would get lost in a research facility that was double blind. It's not possible to have a full ceremony in any of those settings. That would make it no longer double blind. There's all these compromising issues. So those are not things that are researched a lot yet. Bia Labache she was an editor of a really beautiful book on the therapeutic uses of ayahuasca. My copy is from 2014. I don't know if they've updated it since then, but at that time there were no evidence, there were no double-blind or peer-reviewed studies on ayahuasca. So that's, it's difficult to replicate, as we saw with the ibogaine versus noribogaine in a lab setting. We don't know that it's completely going to be the exact same as it would be out where they're taking it in ceremony and with a religious leader. So that's just part of the struggle with the research. And then finally, my own experience of treatment and addiction really is, the goal would be returning to wholeness and helping people to really restore their embodied connection, right? Addictions come from difficulty sustaining within the shared reality, right? It's an opportunity for us to check out, for us to separate, whether it's from intense emotions or relationships or physical sensations. This substance, this behavior, this activity gives us an outlet. And there is a fine line between a healthy coping mechanism and the experiences of addiction. So some of the ideas that I have are really cultivating self-love and self-compassion. And part of that really, my training is as a meditation instructor, and meditation actually changes the structures and function of the brain. So cultivating those experiences can change the brain within 8 weeks, so that those early slides that we saw where there was damage as a result of substances can be shifted and changed and improved as a result of things like medication, or psychoplastogens, right? So they don't have to be one or the other. Practicing intuitive self-care, that for oftentimes for people who didn't have those foundational nurturing experiences that we needed, intuitive self-care is very distant. A lot of my specialty is in eating disorder treatment. And so we help people to start to figure out what is intuitive eating, not only things that you are eating because you feel like they are healthy, or if somebody told you they were healthy, or that's what's out in the world, in the media right now, but what feels good to your body, right? What is your right amount of sleep? I know we've all been told 8 hours, but that's not right for everybody. Some people benefit from 10 hours. Some people benefit from 6 hours. So I think all of the things that we need to be willing to experiment and see what's right for our own experience is intuitive self-care. Joyful existence, right? So finding something to replace it that is better than the addiction is really powerful. Part of the reason is if we just choose to stop or opt out of a behavior, we risk the counter will experience, right? Of willfulness in we don't want to do something because someone else told us, even if that someone else is us. So I would encourage people to just help identify what it is that they need to have a joyful experience and a joyful existence, whether that be joyful movement or healthy relationships. And the next thing, welcoming the authority of our own experience and authenticity. Really being willing to step into doing things because it's what's right for you, not because it's what's expected of you. And then claiming that authentically. Also, finally, building community. So again, that idea that the 12-step programs can be very helpful for people in having a shared experience and a shared community, and also in our willingness to share and be authentic, right? If we have other people who are aware of the kinds of experiences that we had, we're less likely to hide them. And that's important in terms of recovery, because the piece of shame, again, when we go back to that slide of the addiction cycle, that guilt and that shame is another emotional trigger that leads to more engaging in the behavior or the substance or whatever the case may be. So that is all I have in terms of slides, and I am happy to share any, I don't know if there's any questions, comments, things that I could help to sort out.
Thank you so much, Celisa. Yeah, I don't see any questions here. I have a few questions myself, actually. It's a really
Please.
fascinating talk. One thing that I was not aware of was that MDMA also contributes to neurogenesis. So I think that's a really interesting point, because I actually thought I had heard, this was years ago now, I think Dr. Amen used to do brain scans where he'd say, this is your brain on drugs and this is your brain not on drugs. And the one on drugs was not a pretty picture, shall we say.
Right. Yeah. Yeah.
So,
And so, that's such a good point. I think that, yes, he does often, he is in that place where this is your brain on drugs and this is your brain not on drugs. But he also is a big believer in brain rehabilitation. His services provide a lot of support for people that have had traumatic brain injuries and things of that nature. So I think it's important I really always want to highlight how important it is to recognize that there are substances that can enhance brain regrowth and neurogenesis. There's also practices like meditation practice, learning new skills, just learning in general helps people to have that cognitive resilience that can help in the face of trauma. So thanks for pointing that out. I think that's so important for us to highlight, that yes, our brain on drugs might not look great. There was a study, so when you bring that up, there was a study many years ago that MDMA was the images of the brain scan. It was basically that holes in your brain kind of brain scan. That was the outcome. But the reality was it was mislabeled. So it was actually the amphetamine that had caused this brain damage in areas, it was just areas of no activity, low to no activity. But they labeled it initially in the first study as MDMA. So people had that come into their mind that MDMA causes holes in your brain, and that was not the case. MDMA actually promotes neurogenesis, but the their reprint of the study was not as well received. It just didn't get as much attention as the first study that said MDMA puts holes in your brain. So thank you for bringing that part up, because I think that's such an important consideration. Yeah.
Yeah, it looks like we have a couple questions in here. Let's see if we can read these guys. Daniel Aumann's work has been really called into question. Someone is talking about that here, not to mention potentially being a con. They're really going a little further. Can you address this? If you know anything more about Dr. Aumann.
Yeah, so there's a couple of things that I think about that. I don't know that I would personally pay the thousands of dollars to get my own brain scanned. I think it's neat, but I think it would be more of a vanity project. Like, it's not, I don't know that you need to have your own brain scanned, but he has thousands of images of brains and can fit them into separate diagnosis, which I think is really powerful. I have definitely, I've talked to, so the other piece is who is calling this into question, right? Because Dr. Amann encourages the use of lots of supplements and hyperbaric chambers and oxygen therapy and things that are not mainstream and are not psychopharmacology, right? And so the people that I have usually heard criticize Dr. Amann's work are psychiatrists. And you know, and so there's that question of who are the people, but also I do recognize that his work, his brain scans are useful. I think that it's powerful to be able to see an image of a brain and say, this is the brain of somebody with a healthy control versus somebody that has had ADD their whole lives. And I think that the value in that is recognizing we can take away some of the blame. I've loved using brain scans of eating disorders in my own work to help families to step away from the idea that this person is just being willful, right? Like that this person is just choosing to engage in their disorder, whether it's an eating disorder or an addiction, when the reality is this person's brain is injured. This person's brain does not operate the same as it would if they never had the eating disorder or the addiction or ADD. So I think it's important to be able to, even if it's, I refer to Daniel Amann because he has such a huge collection of brain scans, but there are certainly other places to obtain brain scan imaging. If you Google brain scan ADD, you'll find 1,000 images. If you know, so, and you can look up specifically SPECT, S-P-E-C-T scan, and that'll show you how different things are metabolized in the brain. So of course, I have heard about Dr. Amann's work, and I appreciate that he has a collection, and whether you choose to look at those specific scans or not, I would encourage you to look at any brain scans when you're interested in a diagnosis.
I find that really interesting. I remember when I read The Body Keeps the Score, and it talked about how your brain also physically forms differently when you've had a lot of trauma from a young age. You know, I was personally horrified at that. So yeah. Similar idea.
Yeah. And the reality is, so again, you can have brain changes that are created in utero, right? Like these brain changes can be impacted in utero. There are people that are born with what's called synesthesia, right? And that's something that can be induced during a psychedelic experience. But there are also people whose brains just formed that way, where they smell colors or they taste sounds. There's just variants that happen from in utero to trauma to anywhere, but that doesn't mean that we're stuck with that brain, right? Like that isn't the only way for our brain to operate. So that I think the part that's encouraging, Paul, is that you can always help your brain to regrow.
So we've got a couple other questions here.
Of course.
At what point in the recovery cycle would you recommend psychedelic treatment? At the low point or after a traditional treatment program?
So, that's the part we don't have solid answers. We don't have solid research. It's usually because psychedelics for some people, based on their history, can be risky. It's not the appropriate medication for everyone. It's not a cure-all for anyone. And so for lots of people, if they have already tried other treatment protocols and standards that have, like, attending 12-step meetings has no cost and no risk involved. It's almost no risk, right? Like, yeah, you might meet some shady people. That has certainly happened, but it's very low risk. So I would encourage people to take those approaches first. And if those things are not effective and are not making a change, then it would be something to take into consideration. But unfortunately, in this country, the only way to take psychedelics legally is through a study. So if somebody is interested in taking psychedelics, perhaps getting on the list for a study would be a good first step while they're trying other treatments and other strategies. That would be, I guess that's my recommendation.
Great. Well, it looks like I'm not sure about this next question. Someone's talking about kratom, maybe they're calling it Kratos, but
sure,
how to quit kratom if it's kratom, so they can use psychedelics for mental health. Although you could speak to that.
Yeah, kratom is not an opiate. So oftentimes opiates, okay, I'm trying to like think of this question. Psychedelics are not usually impacted by kratom, but it can have an addictive quality. I would definitely talk to a medical professional about helping to taper down from kratom, because it can have impacts on the brain that are similar to opiates. It is not an opiate, but like I said, it can have similar experiences. I would talk to a medical professional about stepping down, somebody that's trusted. That there are a few, they might be hard to come by, but there are a few medical professionals that are open to discussing psychedelics. And also, yeah, I'm not sure which psychedelics they would like or meant for mental health.
Right, it's not clear in the question here.
Okay.
So
yeah, so I mean, I would definitely say I would encourage people to try to talk to somebody about helping them reduce that taper, coming up with a taper protocol for the kratom so that they can have access to other psychedelic experiences.
Okay, someone else had asked a question about microdosing briefly, and does microdosing fit into this paradigm at all?
Yeah, so the research, there is research that long-term use of microdosing had not been shown effective. I think there was like a 2014 study that said that microdosing was not effective for long-term ending of substance abuse or addictions. That is not to say that it might not be addressing other underlying mental health conditions, or again, we have to consider what do we consider improvement? What do we consider adequate treatment? Is it harm reduction? Is it a decrease in the amount of substances some person is using? Or is it complete and total abstinence? So microdosing may not impact complete and total abstinence, but it very possibly could help to address some other underlying mental health conditions, or um, have somebody find a more manageable level of use that is less harmful.
Okay, we have a kind of a psychopharmacological question. What's your opinion on an SSRI and antidepressant plus microdosing? Most seem to not recommend it.
So I am not a psychopharmacologist or a psychiatrist, so I can't necessarily. It depends what a person is microdosing. Um, Typically, microdosing at sub-threshold levels should not have a significant impact or change in the use of an SSRI. However, it could be risky for some people who have a higher serotonin level. Again, we have to consider that everybody's serotonin receptors level are different and variant. There is an idea of what is standard, but that's not the case for every person. With an SSRI and a full dose, there are oftentimes people will report that um, it's a decreased experience. Dr. Benjamin Malcolm, who is also associated with psychedelia, had a really nice diagram where he breaks down different SSRIs and how they would be impacted by different psychedelic substances. So I would encourage you to look that up. Again, Dr. Ben Malcolm. And microdosing tends to be the least risk because it's such a micro dose. It should be sub-threshold and very low. So there's minimal risk to adding that, but people might not see the full benefits of microdosing and an SSRI.
Tara would like to know, will the slides be available somewhere?
Yeah, I am happy to email those out to anybody that wants them.
Okay, great. Just email Dr. Celisa for those slides.
Yeah.
Doesn't look like we have any other questions here. I guess I have one more thing I could note, at least, or my understanding is that DMT is the active ingredient in psilocybin anyway, so it would stand to reason that that would be very neurogenesis friendly,
Right.
for the same
Right.
reasons.
Yes. Yep.
Yeah.
Absolutely. So it promotes neurogenesis. Again, hopefully with lower risks. And there are other substances that it's a very new area of research. I think that term was coined in 2018. So it's all very new, and we're still trying to figure it out. But there are other things that promote neurogenesis. There's definitely supplements. If you look up BDNF, so that's brain-derived nootropic factors, and there's tons of supplements that people have found that are correlated with brain growth. There are, like I said, meditation. There's all sorts of things, breath work. There's all sorts of practices that can help people's brains to grow and recover that are not psychedelic substances, that just so happens to be one of the things that could contribute.
People are saying thank you in the chat. So
Thank you everyone for joining, for being part of our community. I'm always happy to share information as much as possible.
it's great. On behalf of all of Psychedelia, we would like to thank you as well. And it's so great having you as someone of your caliber as a circle leader as well.
Thank
Pleasure.
you. Thank you.